We are going to talk a little bit more about thinking about how consumer incentives will influence drug pricing and the performance of various actors in the drug space. I have a wonderful panel. I just want to introduce everyone. I think the format is pretty similar to what you guys saw before, but we're going to have a couple of presentations, and then we'll have a discussion among ourselves, and then we will call upon you to ask questions. So please be storing them up and thinking of really sharp and concise questions so we can get to a lot of them. So my panel includes Jeffrey Joyce, who is the director. Absolutely. Thank you. My panel includes Jeffrey Joyce, who's the director of the Schaeffer Policy Center at USC. Fiona Scott-Morton, who is a health economist and professor of economics at the Yale School of Management. Adam Fine, who's the president of Pembroke Consulting and the CEO of the Drug Channels Institute. Elizabeth Fowler, who is the vice president of global health policy at Johnson & Johnson. And Steve Miller, who's the chief medical office at Express Scripts. So, Professor Joyce, you want to kick us off?
Thanks, Margot. I'm going to go out on a limb and say this panel should be a little more contentious than the catastrophic copay.
But, you know, in a friendly way.
And this is collaborative work with Karen Van Nuys and others at Schaeffer, and it's been supported by the Schaeffer Center and a grant from NIA. Growing public concern over rising prescription drug costs are fueled by these types of international comparisons. So here's the price of Humira, just an example, a typical RA drug. Its price in the US is 2 or 3 times higher than it is in European countries. And not surprisingly, given this, the vast majority of Americans think the government should do something to control rising drug costs. That ranges from requiring pharmaceutical manufacturers to justify their prices, to government negotiation or capping drug prices, to even importation of drugs from foreign countries. And if you look at the data, actual out-of-pocket expenditures on average in prescription drugs have not increased that significantly over the past decade, but the fraction of folks who are exposed to the full cost of a drug has. So the yellow bars show, these are for large employers in the US. In 2014, about a quarter of large health plans had a separate deductible for prescription drugs compared to, let's say, 4% a decade prior. And we're seeing the same trend in increase in co-insurance instead of a fixed dollar copayment. So in essence, some fraction of beneficiaries are exposed to the higher cost of the drug. Increasingly common, but obviously controversial response among manufacturers is to offer rebates that either reduce or eliminate the copayment on a drug. These types of coupons are banned from federal programs, let's say Medicare and Medicaid, for example, under the anti-kickback statutes. They were initially banned in Massachusetts. That ban was repealed in 2012, and then Massachusetts adopted, will prohibit coupons on drugs that have a generic equivalent. So a multi-source brand that has a generic equivalent. In states like California and many others are either proposing or have enacted legislation to follow the Massachusetts ban, i.e. on multi-source drugs. The response in the commercial sector has been different. It's typically been, let's exclude drugs from the formulary that are highly couponed, or else let's not count the coupon amount towards fulfilling your deductible. So the question today is, should federal or state governments enact legislation to ban copay coupons? Advocates of coupons say it improves access, particularly for high-cost drugs with unique therapeutic benefit. Critics of the programs or coupons in general say it circumvents the plan's benefit design, which is trying to push people towards what they feel are lower cost drugs for the plan, so patients fill more expensive therapies, and therefore total drug expenditures rise as a result of coupons. So we looked in 2014, we scraped the web for the existence and the prevalence of coupons in 2014. We focused on the 200 highest expenditure drugs in 2014 to try and get a sense of what fraction, what prevalence of coupons exist in the market, what type of drugs are being couponed, and what are the characteristics of those coupons. And among the 200, 68 of them were generics, and none of them had coupons. So it's largely a brand phenomenon. It's not surprising. And among the 132 brands we looked at, the highest expenditure ones, about 42 did not have coupons, 90 did. So roughly 2/3 of branded drugs had a coupon in 2014. Here's what a typical coupon might look like. This might be an online ad or a print ad. Here's one for another RA drug or NSAID, where the member is required to pay just $5 out of pocket as a copay. And if we looked in our data on these 200, what we see is the modal coupon. Most plans try and get the copay to $25 or less. And typically, they put a limit on how much you can benefit in a year, a calendar year. It ranged quite a bit from maybe below $500 to as high as $24,000 annual cap on a beneficiary as how much they could save. But I'd say the majority of them promised savings of in excess of $1,000 in a year. And almost all of the coupons had some time expiration. So about half had some, it's valid for X number of uses after the initial use or for 1 year from the start, things like that. The most common was to put a limit, in this case 12 scripts, for example, could be couponed. So most of the criticism of copay coupons have focused on the role they play in discouraging patients from substituting towards a generic. In the sample of our 90 drugs, only 19 of them had a generic equivalent. The vast majority, 71 of them, did not have a generic substitute in the market, but they may have had some other therapeutic substitute. And so what we did is we asked clinical pharmacists at USC to evaluate these 71 single-source drugs that didn't have a generic equivalent, but may have had some level of substitutability. They said 25% of them had a close generic substitute in the class that was a generic. 35 had a reasonably close therapeutic substitute, but that was also a single-source brand. And 11 of the 71 did not have a therapeutic substitute. They were single-source drugs that had unique therapeutic value. So then we looked at, well, what are the prices of these alternatives? And again, 11 of the 71 had no therapeutic substitute at all. 25 of them had generic substitutes, so some other drug in the class that was a reasonable therapeutic exchange, but that was generic, and they were markedly lower in price, not surprisingly. And then 35 of these had a substitute, but that was also a single source brand, and it was very similar in price to the coupon drug, and the majority of those also had coupons. So in some ways, it's couponing other drugs that are similar price.
Can I interject for one question?
Sure.
Are those prices the list prices or the negotiated prices?
These are the prices from Medicare data. So it's actually what's paid by the beneficiary and the plan. Good question. Okay. But the point being, and I think maybe I can synthesize this better, we tried to illustrate the impact of copay coupons on two dimensions. On the vertical axis, its impact on total drug expenditures, and on the horizontal axis, its impact on therapeutic options. And again, moving away from the origin is, we think, better. And clearly, the 19 coupons for drugs that had a generic equivalent increase costs with little therapeutic benefit. They don't expand options for patients at all. But I think that the positive note of that is these are 2014 data. Today, plans have largely eliminated this. Through prior auth and through formulary exclusions, we're not seeing coupons on multi-source drugs and today as we did in 2014. On the other extreme are about 11 drugs that the clinical pharmacist had no therapeutic substitute. They were unique therapeutic value, and this clearly expands options for patients, and they may or may not increase costs. In between these two extremes are drugs that have imperfect therapeutic substitutes, 25 of which had a generic, so I think we could say it maybe expands options for beneficiaries, but it clearly raises costs to the system. And the other 35 improved options, I think, its therapeutic choices for patients and had very minimal impact on cost because the drugs that they induced substitution from were similarly priced, and the majority of those also had coupons. In general, I think that coupons should be seen as a strategic response by manufacturers to higher patient cost sharing and increasing PBM control over formulary decisions. Coupons can weaken formulary compliance. In 2014, 1 in 5 coupons were steering patients away from a generic equivalent. 1 in 8 were designed for single-source drugs that had no therapeutic substitute, and the remaining fell in between. Some that had close generic substitute that was generic and much cheaper, 60% that did not have a sort of a cheaper alternative. So is a total ban warranted? We don't think so. Given the current pricing system, a ban on coupons would reduce access to some therapeutic products for some patients. And coupons should be seen more as a symptom of sort of a dysfunctional and opaque pricing system and not the disease in and of itself. And if you think about who should benefit or who should profit from the pharmaceutical supply chain, I think there's been increasing evidence over time that the pharmaceutical supply chain eats up more of the economic rent and profit than it should, and that the rewards and the risks are largely being borne by the manufacturers, and the innovation is largely coming from manufacturers. So if we're going to sort of tilt the field in one direction, it should be away from the supply chain and more towards rewarding manufacturers for innovative products. But I think the take-home message here is a total ban is unwarranted. I think a ban on drugs that have generic equivalents is reasonable, but I think that has largely been taken care of by the market. But I think excluding coupons altogether would adversely affect some patients and tilt the field away from manufacturers. Thanks.
Terrific. So, Professor Scott Morton, I know you have a more skeptical view of these coupons.
Let me just say one word about the previous panel. There was a little departure from accurate economics there that I just want to fix before everybody goes home with their notes. Okay, there was some discussion of launching at a price that the market will bear and that we have market-driven prices. Let's remember that the market in the United States is very largely Part D. If what you're launching at is a price the market will bear, that means what Part D will pay. So we shouldn't be thinking, oh, there's some correct abstract market price out there that somehow the government is paying through its government program. No, prices are being set in response to the government program. So if we make it very lucrative for plans to get people into the catastrophic region, which we have, because then the government pays a big share of the bill, then they have a reason, along with manufacturers, to raise list price, because that gets people into the catastrophic region fast, and give them rebates to lower the pain. But that helps the plan by getting the patient into the catastrophic region, which is very profitable. So that's what the panel was talking about, changing those rules. But you just have to remember that the prices are being set knowing that these government programs are out there. So that's just important. And that's the problem with this whole world, is that there isn't any benchmark. There isn't any benchmark of a real price because we don't have uninsured consumers. So what I thought I'd do to sort of explain how okay, it's on my laptop, but it's not showing up here. Have I done something wrong? Okay, good. What I thought I'd do is just remind us why we have insurance, okay? Because I think that's really key to understanding whether we want these coupons. Okay, people want insurance because they want to smooth their healthcare costs over time or across people. We don't know if we're going to be the one to get cancer. We don't know if in a year from now we're going to have a massive medical bill, and that's what insurance is all about, creating this really smooth flow so that I pay a premium every month and then don't have to worry about it. Okay, that's what we want. So the ideal thing there would be to just have premiums and no out-of-pocket payments at all. But there are some imperfections. People might overconsume. If they just had a premium and absolutely no out-of-pocket payment, they might consume stuff just because it was free, okay, and not really think about the cost of it. So we need some small copays for that. And then the insurer is responsible for negotiating prices, not the patient. And how does the insurer extract discounts? By walking away, by saying there's drug A and drug B, and I'm going to move my 1 million people to drug B. And that's going to get me a lower price on drug A or B. How do you move people? I belong to an HMO. The Yale HMO just takes one drug off the formulary and out of the pharmacy and puts the other one in, and that's what I get. Okay, but if you're seeing a doctor in the community, a kind of a fee-for-service arrangement, then that doctor is not under the control of the insurer. The insurer can only shift share through you, the patient, by giving you a copay. So drug A is $5 copay and drug B is $70 copay. And that is the tool being used to shift you from drug A to drug B. That's the tool that enables the insurer to pay less, to say to drug A, your price is too high, I'm going to move everybody to drug B. And I can, because I will give them copays that make them move. And then you won't have any business. So we need copays to reduce moral hazard, this overconsumption, and allow the insurer to shift share. That's why we need them. However, ideally, we want as much full insurance as possible. These copays, we want to set them to do those two things, but that's it. We don't need them to be higher. They don't serve any other purpose. So our current problem is driven by high healthcare costs where employers want to get out of paying those costs, and so they make a high deductible. They say, all right, that reduces the cost of my pharma benefit because the first $2,000 are being paid by the employee. or a specialty tier. I'm going to have the first 30%, or I'm going to have 30% of the $100,000 biologic paid by the patient, and that just reduces the cost of the benefit. Those kinds of out-of-pocket payments are not achieving either of these things. They're not reducing moral hazard, because $30,000 for your biologic is not going to, you're consuming it because you need it. And the very high copay is once you get to a level where you can shift people from drug A to drug B because they prefer to pay $5 than $70, having them pay $700 or $600 for their EpiPen in the deductible is not helping with that either. Okay, so these high out-of-pocket payments aren't doing anything useful, but they give the manufacturer a strategy. So I'm going to give if I'm the manufacturer, now I give the money to the patient to help them with their copay because they want that, okay, because it's so high, in return for them consuming the drug. What's the problem with that? The patient is insured. So there's an externality. The patient consumes the drug and everybody else in their plan is paying for it, okay? The payment to the patient then stops, full stop, in the insurer from being able to switch them around. They don't pay they pay $5 if they have the generic, $5 for brand A, $5 for brand B, because they get a coupon. And the insurer can't move them. Once the insurer can't move them, they say to drug A, well, your price is kind of high, and we're going to shift people away. And drug A says, no, you're not. I've got everybody on a coupon. So you can't, not going to reduce my prices, and equilibrium prices stay higher. Okay? So that's the problem here, is that the coupon defangs the only tool we have in the branded context for lowering prices, which is getting drugs A and B to compete for the business of the insurer, because the insurer can move patients back and forth. Okay, that is a really critical tool to lowering prices. So that's the problem. The intuition here is, suppose we said, okay, we're going to let the head of the city transportation department, who chooses which roads we're going to build, to let, and by the way, we the taxpayers pay for the roads, we're going to allow the head of the transportation to take money from the construction company to help pay for the road. The construction company is going to give the head of the Department of Transportation some money because they want to be chosen. Okay? Do we allow that? No, that's a kickback, right? You're taking a person who is spreading the cost onto everybody else, letting them take a kickback from the provider, and then choose that provider's product. Okay? That's not a good way to design public policy. Patient coupons and financial aid to insured patients are kickbacks designed to reduce elasticity of demand. Okay? And what they do is they raise prices. There's a clear conflict of interest here. I take the coupon, my costs are lowered, and the cost of my very expensive drug is passed on to all of you. Okay? So that's why we don't think they're good public policy. So the ultimate harm is higher prices. The PBM, as I said, can't shift share away from a brand with a high copay if the brand's going to undo the high copay with the coupon. So I just gave you a numerical example. You could have a $15 copay and the expensive brand has a $70 copay. Normally everybody would pick the low one. Okay, but now suppose the brand gives a coupon that lowers the 70 down to 15. Now A and B are the same. Why would the consumer move? Why would the consumer listen to their insurer and say, oh, actually drug B is cheaper? They won't. So the threat, give me a lower price or I will move my business, becomes an empty threat, and the patient is shifting costs. Okay, so what is the right policy? If you just take away patient coupons and financial aid, you expose patients to very high cost. So if you're going to do this, you have to have a policy pair. Okay, it's very important that these two things go together. I would say you absolutely have to have some copays in order to allow competition between brands to exist in this market through the PBM and the insurer. So you have to forbid manufacturer coupons or any kickback. In general, we can't have the manufacturer be the one helping the patient with her drug costs. That's not good public policy. But in that world, employers or insurers could design a plan that had very high out-of-pocket payments, and there would be nothing that consumers could do about that. So we have to pair this ban with limits on out-of-pocket payments. So you could pick a number. California picked $250. You could pick $150. When I was on a panel here last year, a representative from CVS Express Scripts said that about $100 difference in copay is enough to move people around. So if I faced drug A at a zero cost and drug B at a $100 out-of-pocket cost, I would be inclined to consume drug A. That kind of difference is the difference we need. So we could allow for co-payments up to, say, $150 per month or course of treatment, and that would be enough to allow the PBM to do its work and be enough to prevent moral hazard. I wouldn't be consuming things because they were free, but at the same time, we would be protecting patients because that would limit their out-of-pocket costs, but at the same time, we would be taking the manufacturer out of the picture. Okay? Allowing the manufacturer to pay patients to take their drugs, okay, is perverse, right? You create a real conflict of interest because the drug costs $5,000. I'm going to pay the patient $100 to take a $5,000 drug. Okay, that's not going to result in a good outcome, right? We're going to see that prices are going to be higher, and there's going to be no limit on the ability of the manufacturer to set a high price because the PBM is not well armed. Okay, so that was all that I wanted to say. Thank you.
Thanks. Adam, you want to? So I'm curious a little bit about why you think we have this system with these coupons.
Okay. Well, first of all, I want to thank Jeff and Fiona for two very different and very interesting perspectives on a pretty complex issue. There we go. Okay, here we go. Hi. Thanks to Jeff and Fiona for two very interesting and different perspectives on a pretty complex issue. And I have just a couple minutes to give some thoughts on this. You know, and I think it's important to, it reminds me of something I learned in graduate school many years ago. In theory and practice are the same. In practice, they're different. And if we think about the world of the pharmaceutical industry today, we really have not, people's mental model is this image of drug reps knocking on doctors' doors, this sort of primary care blockbuster. But that world is basically over. The world of the pharmaceutical industry is bifurcated. We have, as some people have mentioned, about a 90% generic dispensing rate today. Roughly 85% of people pay less than $20 a month out of pocket before the effect of any coupons. 95% of people pay less than $40. I put the data on drug channels yesterday. And then we have this other side of the story, this very small percent of people who are paying very high out-of-pocket costs, very small patient populations, relatively expensive drugs, relatively rare conditions. A lot of the mainstream conditions we can treat with generic drugs. So the industry is bifurcated, and that's where we're having this kind of conversation. We don't really need to go help the same people with those generic drugs in the same way. And generic drugs are in a massive deflationary phase right now in the last couple of years. But on the other side, we have an enormous amount of cost shifting going on, where we've seen from 2 to 3 to 4 to 5 tier plans now, where those highest tiers are often co-insurance tiers. And the patient's obligation can be hundreds or thousands of dollars. And so we have this kind of interesting diversity here. And part of what is driving this now, if you think about where the money is flowing and what's affecting the patient, you know, we talk about rebates as money going from the manufacturer to the payer, and they're using that to, who knows what they're using it for. Right now, rebates are more than $100 billion, and they're being balanced on an increasingly small number of prescriptions. So we have you know, and I've termed this the gross to net bubble, this very wide gap between the list price and the net price. For some patients, they're exposed to that list price because they're in a deductible phase, or they're paying a co-insurance as a percent of the list price. And for many of those drugs, their payer may be collecting a rebate that they never see. So we have some really interesting challenges when you think about patient cost sharing. We have some principal agent problems. We're at Brookings, I think I can say principal agent, right? Yeah, I think I can.
Moral hazard.
Yeah, did I mention moral hazard? Yeah. I got to work in adverse selection.
I'm being much nicer than usual, guys.
So thanks. But, you know, think about it. Your employer, if you think about commercial insurance, which pays for about 40 to 45% of all outpatient drug costs right now, they may or may not have your our best interests at heart. They may want to set up a tiering structure that prevents certain people from working at their companies. Just last week, Publix, it was revealed, didn't pay for HIV drugs. Why? I don't know. We can guess. They were sort of embarrassed into doing it. We have the employers collecting large amounts of these rebates, which may or may not be shared with you and me. One survey found that 70% of employers didn't share the value of the rebates with the patient. So you may be paying 20% of that drug, and then your employer may be collecting a rebate for that. In some cases, we have totally broken categories where competition is so intense that the net price after rebates has been flat or negative. Short-acting insulins is the classic example here, where the net price has been flat, but the list price has gone up at like a 45-degree angle, and that gap is a whole bunch of money being poured into the system to the point where the employer actually doesn't actually pay for anything. They're just collecting these rebates and spreading it around. So when we think about policy solutions, we have to be very cautious about what's happening here. When the manufacturer steps in to provide that co-payment support for a product which, as Jeff pointed out, doesn't have a generic alternative, is maybe a single-source drug, is maybe a specialty drug treating a small patient population, in some sense it's another form of discount. It's another discount they're providing that either the plan would pay or the consumer would pay, but somebody besides the employer is paying when the manufacturer steps in. So we have to be really cautious about sort of trying to over-engineer the world we're in now, where we have a lot of different actors acting in a lot of different ways, and I think be honest, Fiona, I think using very loaded words like kickback to describe a very complex system of funds that are flowing around with entities that have very widely disparate incentive structures is, in my opinion, not the way we want to think about providing access to needed therapies for people who have rare and unusual conditions. And I'll make one final point, because I think I have 10 more seconds. I want to be really cautious when we're talking about single-source products for people with conditions like cancer, MS. I don't think you need to be bribed to take that product. This is not a situation of deciding, should I get an iPhone X or should I stick with my iPhone 8? We're talking about medicines that are crucial to health. And so I don't think the word kickback is applicable here because I think the word choice is not really relevant when it comes to these medicines. And the whole nature of insurance is, I think, as Fiona eloquently stated, to help us get over these kind of tough situations which, frankly, any of us could find ourselves in. So with that, I will let the panel move on.
Yeah, I'm curious, Elizabeth. Oh, sorry.
Go ahead. I'll do a follow-up. Okay, sorry.
Oh no, I would like to move on, but I'm obviously you, Elizabeth, you're viewing things from the pharma side. How do you guys think about these coupons? I mean, I assume kickback is probably not the preferred term, but
yeah, probably not. So I think it's one strategy to make sure that patients can afford their drugs. Is it ideal? No, I don't think it was something that's dreamed up as like this would be an ideal way to move the market in it. I mean, we saw some of that in Jeff's comments. It's not ideal, but it's one of many strategies to try to make sure that people can afford their drugs. So I guess, could I just step back and make a few other remarks? And when we did this call, the prep call, we were told that we could start with sort of anything we wanted to say. I don't know that it was that broad, but I do want to...
It is now.
It is now, right. I do want to respond to the previous panel because I thought it was really interesting, and it was they raised a lot of good points. And one of them was, I was really glad that both of the congressional panelists said that they were open to relooking at the budget deal from last week, because I think increasing the share of discounts that pharma pays and then shifting that mostly to the plan instead of patients is not probably the best policy. Would love to see sort of rethinking about moving more of that benefit to the beneficiaries. So was really glad to hear that there was some openness to thinking about that. I don't know if it would happen before March 23rd, but certainly open to that discussion. And then also just on Part D, as somebody who was there and worked on Part D legislation in the Congress, in Liz's job actually, the world has shifted a lot since 2003. We've moved from a world where the focus is on chronic conditions, diabetes, chronic heart failure, hypertension, to a world where there's so many more innovative products and specialty products. And so I think the world hasn't caught up in terms of the way that the benefit is structured and the way that the costs are distributed in the program. So really glad to think that there's a way to rethink that now that we have a different world for pharmaceuticals, and would love to see something that protects beneficiaries and their out-of-pocket costs. And so that sort of brings us to our current discussion. If you look at where cost sharing has moved since 2006, that's the year that the Part D program was implemented, deductibles have increased by 300%, and coinsurance has increased by almost 90%. That's across the board, not just for pharmaceuticals, for all healthcare. And unfortunately, in healthcare in this country, everything moves up, nothing moves down, and that's across the board and just sort of our reality. But cost sharing has had a real impact on adherence, and if you look at abandonment rates, which I think we haven't really talked about, the more you pay in cost sharing, the less likely you are to take the drugs. That has a really negative impact on patients. So patients are more than twice as likely to abandon brand medicines filled in the deductible than those filled when the benefit kicks in. And I think some more data, going back to your point about cancer drugs and MS patients, that it's really, when you're thinking about those important health choices, it's not really a choice. An abandonment of oral oncolytics, if you look at the patients with the highest cost sharing, they're more likely to abandon or not fill their prescriptions at all. So if claims with cost sharing over $500 had 4 times more likelihood of being abandoned compared to drugs with a cost sharing of less than $100, and this is for patients with cancer. For patients with MS, a 2009 study found that abandonment was 5.7% when the out-of-pocket was $100 or less, but the odds of abandonment when the out-of-pocket expense was greater than $500 was 7 times more likely. And this has an overall effect on not just healthcare outcomes for those particular patients, but also on healthcare spending overall. You're more likely to maybe land back in the hospital, experience an ER visit, et cetera. So, and getting back to your question, Margot, there are a lot of strategies to try to make drugs more affordable. Copay assistance, patient assistance programs, the foundations that we've talked about, and coupons is one of those. Coupons are not ideal, but it's better than patients not getting their drugs. And as the research that Jeff explained shows, in many cases, coupons are used when there's really no alternative. So in that instance, it does look like it's more of a strategy to try to make the drugs affordable than to shift market share. So we keep talking about these issues in terms of economics, in terms of programs, but these are real beneficiaries with real health issues. So a better way, there's probably a better way to think about this, and I hope we get to the point where we're talking about policies. Looking at an out-of-pocket cap, I think, in Medicare is really important, and President Trump and Senator Wyden on the same page, who would have thought, but good to see that discussion is potentially now bipartisan. Lots of focus on the spread, the growing spread between list and net prices for drugs. And cost sharing is sometimes and often based on the list price and not the net price. And that's a growing concern for the industry. Something looking at policy options, looking at this growing spread and the price that the consumer pays or the patient pays at the point of service is an important part of the discussion. And imagine if this was hospital stays or physician stays, and your cost sharing was based not on the negotiated rate that your insurer had made or the discounts that were made with the negotiated rates with the hospital, but based on the actual billed price. I think that would not be tolerable. So looking at passing rebates on, directly or indirectly, should be part of the discussion. I saw this week that researchers at Johns Hopkins suggested that maybe instead of passing rebates on to the patient, they could be passed on to the payer. Let's have that discussion and see what that looks like. But really, I think from the industry perspective, what we would really like to see is a movement towards value. And I know this is now an overused phrase, the whole notion of value in healthcare, but looking at innovative payment arrangements based on value, that if you bring value into the equation and payments are based on value, that we can look for a way to make those drugs more affordable. If we really believe that they're the right drug for the right patient at the right time, then let's make sure that it's affordable for the patients. So look forward to the discussion, but those are my reaction.
So, Mark, sorry, Steve, will you tell us what it looks like from the PBM end? I mean, how distorting do these coupons feel to you in terms of, managing the plans the way you want to? And I also would hope you could talk about the what several panelists have mentioned, which are these very high and rising cost sharing that beneficiaries are facing.
Yeah, so thanks for having me. And this is obviously a complicated problem. A couple facts you should know, and that is, despite what we hear in the marketplace, the system is actually, for most patients, working better. If you look at our data, the most recent data on comparing 17 price increases to 16 price increases, the drug trend for the United States for our commercial plans went up 1.5%, lower than inflation. And when you look at cost shares, we have worked really hard to keep cost shares down, and our plan sponsors have kept it down. The average prescription increase cost share went up 12 cents. That is 12 pennies per prescription in the last year. Now, do not get me wrong. There are many, many patients that are really hurting. Those patients that are unfortunate to have a serious illness and they're facing the full cost of the drug, they are hurting, and so we have to have policies that make a difference. So let's talk about coupons. Remember that coupons are put out there to protect market share. Pharmaceutical companies are rational. Remember, they are not even asking for your ability to pay. They don't look at your finances for a coupon. They're indiscriminately given to everyone. And they're there to protect the market share. And if you interpret Jeff's data just a little different, that is, if you look at the 90 drugs that have coupons, 84% of them had an alternative choice that was probably cheaper. Either a generic choice 20% of the time or a therapeutic switch the rest of the time. Only 11 drugs didn't face competition. And those 11 drugs probably didn't need to be given. Those were for things like Botox or other lifestyle drugs that don't actually need to have coupons, but they get coupons because they want to buy market share. Patient assistance programs are much different. Patient assistance programs are designed for patients who have financial need, and financial evaluation of the patient is done prior to giving them the copay assistance. And so copay cards have been outlawed by the federal government. Massachusetts outlawed them for a while until pharmaceutical manufacturers were able to pressure them to pull back on that. But studies by Aaron Kesselheim, Leemore Daphne at Harvard, and others have shown that coupons raise the price. And not only do they raise the price because they prevent switching, but they raise the price because they let the pharmaceutical manufacturer bring the price in at a higher entry price. Because if you can take the bullseye off the manufacturer, it allows them to have more price elasticity. Now, let's talk about these patients that are paying excessive amounts. We strongly support having to do something about this. This is, as Fiona talked about, we've actually done price elasticity across all classes of drugs. I'm a transplant kidney doctor. I know that if my patient's copay goes above $150, they start abandoning their drugs. Now think about the crime of that. You've gotten the gift of life, you've gotten an organ, and adherence rates for transplant patients are around 80%. And so that's unacceptable. It adds to rejection, hospital visits, loss of organs, and often loss of life. And so we need to make so that there are sensible caps for people in all insurance forms, not just in Medicare Part D, but even in the commercial insurance. We need to have sensible caps to achieve what Fiona's talking about. We need to have the tools to help move the patient to the right drug. But we also have to protect the patient at the high end because we can't subject them to these incredibly high prices and believe they're going to be able to take their cancer drug, their transplant drug, their MS drug, or other types of drugs. So I'll end my remarks there, but I think that, as you can see, it is a really complicated issue. I believe that coupons actually don't buy access. They're really just buying market share for the pharmaceutical companies. If you really want to talk about relieving patient suffering, you need to look at patient assistance programs, which are also funded by the pharmaceutical manufacturers and which are really help to make sure that those who have financial need are getting the help and not just indiscriminately to the marketplace.
So I'm going to just take my prerogative and ask a question or two of our panel, but everyone else get ready. I'm curious what feels like the right spread. You know, it seems that everyone on this panel is concerned that certain patients are being asked to pay extremely high cost sharing on drugs, you know, whether it's a percentage of the list price or whether it's, you know, just these very high deductibles on pharmaceuticals. And I guess I just wonder, like, is the $100 that or $150 that Fiona talked about, does that feel like the right spread to all of you? What in an ideal world would be the right limit or the right spread between the kind of drug that you want, you know, the lower cost drug that you want to steer people towards, but the you know, other option that some people might still choose to take?
You know, we've looked at this in, you know, when you look at tiered programs, we actually know that for when you go from generics to a branded product, a copay difference as little as $40 will help move those patients, a large percentage of those patients. Now, there are some patients that are not economically rational, and they actually will pay the excess to have the branded product when there's a, you know, even a generic equivalent. And remember, when a drug goes generic, the pharmaceutical company actually raises the price on the brand, which doesn't seem logical, but because those patients that are really loyal to that brand, if you're really loyal to Lipitor, you'll buy Lipitor no matter what price it goes to. And so we know that $40 is usually important between the tiers, first tier, second tier, third tier. When it comes to abandonment, and this is the specialty patients, these are these patients with the incredibly high copays, this is the one that's getting into catastrophic, you need, we've done price elasticity, we know abandonment goes up at above $150. And so I think that somewhere between $150, and you can index it for inflation or whatever, but I think somewhere above $150 should be the cap that you're looking at.
That's really interesting data, Steve. You know, there's kind of an underlying assumption here that I just want to call out. We're all kind of talking as if the price is a thing. The price, you know, although it sounds like it should be a thing, the price is, there's a lot of different prices. And it's not necessarily one thing to say there's a list price, there's a net price, there's the net price the employer is paying, there's the price the consumer is paying, there's other prices in the whole drug channel system. But I don't think we should just automatically assume that the plan is always making the best decision. We don't know. We don't know. When someone tells us, well, this is the lowest cost, you should switch, maybe it's therapeutically close, maybe it isn't. You know, there's certainly some categories where different plans cover different drugs, or drugs get moved from a formulary off a formulary, and your physician may or may not agree with that. Now, I'm not a medical doctor like you, Steve, so I can't really comment on medical switching or non-medical switching, if you will. But I think we have to be careful about saying, you know, what exactly is the incentive? What is really the price that's causing them to raise my copayment? I would like them to be aligned with me, but they have other incentives they're thinking about, both the PBMs and the plan and my employer, that may or may not be aligned with my personal healthcare choice. So I want, you know, we have to be careful of just assuming that everyone is always looking out for my best interest.
And to follow up on that, I think it's a very good point, Adam, is that we overlook, there's been consolidation in the PBM industry. So the three largest PBMs, Express Scripts, CVS Caremark, and Optum, have about 80% of the market.
Your own study said 66.
It's
Not my
actually,
study,
it's
but
we have
actually 73% of adjusted claims in 2017.
We shouldn't quibble over
minority.
that. The point being is, if you look at the national formularies of the large PBMs, you'll see drugs even within a PBM, within CVS Caremark, an MS drug is preferred one year, it's excluded the next, and vice versa. If you look across the PBMs, you see a drug that's preferred on Optum's formulary, and it's excluded from CVS Caremark or Express Scripts. And that may not be a problem if the drugs are homogeneous and they're equally effective, but when you have heterogeneous responses and the drugs don't always work for the same, you want to have those options available. And you say, what happens when I lose access to a formulary of Express Scripts or CVS Care, and I lose access to 50 million people? Well, those 50 million folks have an excluded drug that they have to pay out of pocket for. And so I think part of the coupons, in a perfectly competitive environment, you're right, coupons are not ideal, but we're not in a perfectly competitive environment.
But do the coupons apply in that situation where the drug is off formulary?
If it's off formulary, no, and that's been a response of the PBMs.
That's actually not how the system works, though. That is, there's grandfathering, so when a patient's on a drug and having a good clinical response, even when it changes off the formulary, they often still have not only access to it, but they get the reduced price of the copay. So this blanket statement that people switching formularies actually lose access to the drugs is not how the market actually works.
But I'd interpret Jeff's comment as meaning we're assuming there's some, totally rational, completely sensible agent who's saying, well, this is obviously the best drug. And then if you happen to change jobs and you get a different formulary, someone's saying, no, actually, this is the best drug. Your other guy was wrong.
Well,
so that's I think, there's a diversity.
It's not really the best drug. It's which one is going to offer the best terms today. We might think that a Honda and a Ford are both fine cars. If one of them is, going to offer me a $20,000 discount, I'm going to drive that one. It's not that I think the other car isn't fine. So the agent who's creating price competition here is the PBM. It's only by being able to shift people from one drug to the other that a low price can be extracted. So if the PBM goes out and says, well, I really want to have all drugs, A, B, C, and D on my formulary, then what kind of bargaining can they do? I'm going to exclude you if you don't give me a lower price. Well, no, I've already promised not to exclude anybody. I've already promised not to favor one drug over another by giving them more market share. So this is a very important tool, and if we don't have this tool, we don't have price competition between drugs, and that's just a very expensive thing to give up. If we want to give everybody access to every drug every minute, then I think we have to have some kind of price regulation, because then there's no way to stimulate competition. If we have a formulary, we don't have to have price regulation. We can say, look, there's two of you, and you provide a similar benefit, and I'd like you to compete for my business. And that's how we do a lot of markets in the United States. It works pretty well.
All right, I want to make sure we have. I'm sorry. I want to. No, I'm the moderator. I am interrupting all of you. Notwithstanding this great debate, but I do want to make sure we have time for some audience questions. Okay. So up here in the front. Do we need? I apologize. Will you just wait for the microphone?
Give your name.
And will you please, everyone who speaks, please tell us your name, and also just be mindful of how long you're speaking so that other people will get a chance.
It's not a statement, it's a question. So, Catherine Capps with Help to Resources. And I know there's about 10,000 medications available, prescription medications available on the market today. And this may go from more the catastrophic area that you've been discussing this morning to more of a what are the PBMs doing and what are the manufacturers doing when we look at a kind of the movement toward curative therapies that also require diagnostic testing. I'm interested in what the PBMs, if we're talking about switching formularies and we're talking about moving there, what's the accountability for appropriateness? We've talked about access and we've talked about affordability, but appropriateness becomes one of those three areas and three buckets. So I'm interested in understanding from a manufacturer standpoint and then the PBM standpoint, what's occurring there when we have curative therapies that also combine with diagnostic testing for more precise medication use.
Well, I'm hoping that they're matched up and that where there's a patient that potentially could benefit from the right therapeutic, that there's the right diagnostic tool that suggests that that's the right therapy for the patient, and that they're both covered in a way that's affordable. So is that happening in the market today? I don't know. And I guess as medicine becomes more and more sophisticated, I'm not sure that our current tools are equipped to deal with some of that. And yes, maybe for 90% of the market it is, but for that 10% with very high cost cases and very expensive diagnostics as well as therapeutics, I'm not sure our current system, whether it's Part D or commercial, is equipped to deal with that and covering the right things at the right time.
Yeah, so it's a great question. So we actually believe that diagnostics and therapeutics are being more linked together, especially for expensive diseases. As you're probably aware, there's 70,000 genetic tests out there today, of which only a couple of them have actually been proven to be beneficial. And even amongst those genetic tests, let's take BRCA1, the Angelina Jolie, there are 61 approved CLIA labs, which means their quality is identical, yet the price difference for the test is actually ranges from $250 to $5,000. So one of the tools we put in place is actually We're working with our physicians to not only recommend which test to order, we're also helping them steer it to the right location so that it's at the highest quality at the lowest cost. We're then helping those doctors interpret those tests and then getting those patients on a care pathway for treatment. But this is going to take a lot of change in the benefit, what's going to be paid for in the pharmacy benefit versus the medical benefit. This is why we actually purchased a company called Evacor. It allows us to do this across both benefits. And so I think, and when you think about, someone mentioned this, we have to move towards value. I think Liz mentioned this. And so when you look at it, we're doing really unique, innovative things on the payment side, including amortization, value-based contracting, adherence guarantees, and other things, because we're going to have to get from this unit cost to something different, especially in the era of the ultra-expensive curative medications.
Oh, I have to let Paul ask a question. It's his show.
Oh, thanks, Marco. Paul Ginsberg, Brookings, and USC. I've heard a lot of economic terms in the discussion this morning, but one term I haven't heard is price discrimination. And when we talk about a single source drug without a therapeutic equivalent that has coupons, in a sense the question is, if it's patient assistance really steered to low income, then that's probably a type of price discrimination that we think is maybe okay. But is that really being steered? Are patient assistance plans really just focusing on low income patients, or are they really masquerading as coupons, which then means this is going to affect the price the drug is introduced at? So any comments about issues like that?
Well, Steve covered it, I think. I mean, in the sense that the coupons are freely available, as Jeff's research shows, so they're not price discrimination. But patient assistance, where I have a 30% copay on a $100,000 drug, that's when I send my financial information to the manufacturer and get patient assistance. So that is price discrimination.
That's right. Actually, one thing I thought of is that if it is going to be price discrimination, truly channeling the discounts to low-income people, who should be doing the judgments? In the sense, is this something that governments or a foundation should be doing as opposed to the manufacturer?
Right. So I think we have outsourced a lot of this problem to the manufacturers, and I agree with you. My instinct is that if we're going to help people pay for drugs, we really as a society need to do that, the government or some neutral party, and not the manufacturers themselves or patient assistance foundations funded by manufacturers, which are not going to be entirely neutral.
Can I just challenge this notion of financial assistance, too? I mean, again, I'm going to go back to my employment example. The average household income in the United States is about $56,000, something like that. And some of these specialty drugs, which affect 1% to 2% of prescriptions at most, have an average prescription price of maybe $4,000 to $5,000 with maybe a 25% coinsurance. So the average American is not going to be able to say, oh, I've got to pay $1,500 out of my pocket for a couple of months until I hit my out-of-pocket deductible. That's an untenable situation. Now, the plan could cover that. The employer could cover that. But instead, they've said, okay, manufacturer, we dare you. We're going to put this incredible burden on the patient. And if you don't step up and lower your price and give more discounts into the market, you'll sell zero. So, again, we're thinking of this as, these loaded words like kickback. But, financial assistance for the average American would be, okay, your plan has decided they don't really want to give you a very generous benefit. So we, the manufacturer, are going to essentially give you another discount off our list price, but instead of giving it to the PBM, to the plan, where it may or may not reach the patient, we're going to give it directly to the patient. So again, I think, when you think about these circumstances, they're not so cut and dried, and that's why I think you really have to be cautious but when we talk about policy changes.
Well, and from the manufacturer perspective, those patient assistance programs are sort of income targeted. So you have to fill out an application. There's an evaluation about affordability. The coupons, I think, and going to the question, when you're looking at a sole source drug and looking at potentially on a specialty tier, you already know, you have your own market research. I mean, we have our market research. You know who can afford it and who can't. And it becomes largely unaffordable. And so I think the coupons, it's not just a matter of, well, I want to bring everybody in and it's a market share issue. It's an affordability issue, and making sure that patients can afford them, because you've already done the research. You know where it's going to land on the formularies, and you know that it's going to be a problem for a lot of patients. So maybe it's indiscriminate, but
One last point. I think we forget, and Fiona mentioned, what is the primary aim of insurance? It's to protect from catastrophic risk and financial loss. But a second implicit part of insurance is a redistribution from healthy to the sick. And the way the current system works right now, with very high list prices and these rebates that go through the PBMs and maybe to the plan and maybe go to lower premiums, that implicitly doesn't affect the person who's incurring the cost of the drug for which the rebate is generated on. So in essence, the current system is a redistribution from the sick to the healthy. It lowers the premiums of everybody in the plan, whether they use a drug or not, on the back of the person who's using that high-cost drug.
Yeah, I mean, I've used the term reverse insurance to describe this situation, and I think the other thing to remember is there's a range of payers out there. We have a very diverse system, and just take the employer market, 40 to 45% of the market. Some employers say, my employees are really valuable. They get gold-plated coverage. Others say, my employees are generic factors of production. I don't really care. Here's a 25% coinsurance. Have a nice day. So the pharmaceutical manufacturer is selling into this market, which has very different price elasticities. And some may say, hey, $100 copayment for you because we love our employees. And the other people say 25% coinsurance. Okay, manufacturer, you want that extra sale? You've got a discount. So it's in other words, to say the market is not working, you're really seeing this kind of, price discrimination occurring. And I don't like the word discrimination because it has other kinds of connotations that I don't think are appropriate. But you're really seeing different prices in the market based in some sense on what that plan is willing to pay for the agent they're negotiating on behalf, or the principal they're negotiating on behalf of. That's, again, these differentiated incentives. We have a lot of different crazy incentives in this system.
In the purple, here in the aisle.
Hi, I'm Julie Cantor-Weinberg with Prime Therapeutics, which is a PBM owned by 18 Blue Cross Blue Shield plans. Doesn't some of this discussion, though, ignore the larger market? For example, I take Restasis. I pay very, very high cost sharing for it. It treats dry eyes, but it's the drug that was sold to an Indian tribe to delay generic competition. So, my cost sharing, sure, a coupon might help me, but it would be more helpful if, to quote the FDA commissioner, we could stop the shenanigans and get more generic competition on the market faster. So I don't know if that's a question or a comment, but thank you.
I'll just say that, we actually, and we put out a policy statement a couple weeks ago, pay for delay and all these other shenanigans things are driving up the cost of health care. As you know, for instance, Amgen and AbbVie entered into a deal that was not publicly disclosed, in which the generic version of Humira will be available in Europe this year, but it won't be available in the United States till 2023. And so when you have these things going on and you can't get biosimilars into the marketplace, which could actually reduce the cost by tens of billions of dollars for Americans. And so we need to do everything we can. And Scott Gottlieb has been a breath of fresh air at the FDA. He is aggressively trying to get through the generic backlog, but he's also using the power of the agency to prioritize generics that are in short supply to get those applications moved to the top. And so I think you're going to see it will take time. It's like turning a battleship or an oil tanker. It will take time, but I think you have a real advocate at the FDA who's going to try to drive down generic prices. And to Adam's point, generic prices overall continue to come down. Over the last 8 years, generics have deflated by 80%. So generics continue to get cheaper and cheaper, and that doesn't mean there aren't some really high-priced generics, as you've heard before other people say, but overall, the generic marketplace is working.
And actually, Steve, I'll bring up something you brought up earlier. I know we're talking about all these problems, but I think you said commercial spending increased by 1.5%. Half of that increase was utilization, more people taking more drugs, and half of it was price, so 0.7%, if I remember correctly. So I know we're talking about this, this terrible problem, but, I'm sorry, 1.5% spending growth doesn't sound like, the sky is falling. I mean, the rhetoric around drugs and drug spending is totally disconnected from some of the data and facts. I mean, people who read my blog know my favorite saying in the world, everyone's entitled to their own opinion, but they're not entitled to their own facts.
Right here.
Hi, Christy Robinson with Matrix Global Advisors. My question's particularly for Fiona, although anyone's welcome to it. For drugs like the 11 in Jeff's study that are single source with no therapeutic equivalent, I assume that you still see a problem with coupons with those. I wonder if you'll explain why.
Sure. I mean, my feeling is that if we're going to ban coupons, we have to restrict the consumer exposure to price. So as Steve said, something like $150 for a prescription is about right in terms of creating incentives and not creating too much hardship. So you need those two together, right? If you banned all coupons and financial aid and you didn't limit consumer exposure, that would be very dangerous for consumers. What we've got now is increasing prices, it sets up incentives to increase prices. Why do I think it's important to ban coupons for everything? Because you never know when a therapeutic substitute will be invented, and we don't really know whether there's a therapeutic substitute for perhaps some segments of the population. Or there could be a step therapy. If this is a cholesterol drug, perhaps we can try you on drug A for a few months. If it doesn't work, we move you to drug B that's more expensive. So you might call that drug B not having a therapeutic substitute because it's better, but maybe there's a way to create some elasticity of demand nonetheless. So I think it's easier also to just have one public policy if you're going to have it, and because the process of invention is always creating, we have a hepatitis C innovator, and then a year later we have a second hepatitis C. So often something without a good therapeutic substitute today will have one tomorrow, and so I think if you took away the coupons and the patient assistance and you added a cap on expenditure, then you'd have a lot of competition, and that would be really great.
Can I just say that if there's a public policy that says that coupons are allowed for single-source drugs, but if there's a therapeutic equivalent, then they're not allowed, presumably, when the therapeutic equivalent comes on the market, the coupons aren't allowed and the manufacturers are going to comply with that. It's sort of suggesting that there's games going on that sort of skirt.
Well, one of the things that's tricky about these coupons is it's really hard to know who's using them. I mean, there are rules against them in various places, but actually if you go to the drugstore and you swipe, it's really not clear how anybody in your insurance company or anywhere else is going to figure out how you paid for that product. It's not easy to track these. It's very hard. The reason we don't have more studies of the effect of coupons is because we can't measure their use. So if we can't, and if patient assistance from the manufacturer arrives in the form of a check, and then they pay their out-of-pocket costs, we can't track that either. So part of the problem here is we really don't know very much about how much of this patient assistance is happening.
I actually think that is a little bit of a simplification of what's happening in the marketplace. Most, and I'll let Steve talk about his company specifically, but most PBM mail pharmacies will not accept copay coupons of any kind. The specialty pharmacies often will accept coupons simply because those are often single-source drugs for exactly these co-insurance situations. Now, I, as a payer, let's say I'm an employer, I could say to my employees, you know what, you have to use the mail pharmacy because that's the way we're going to just lock down this coupon situation. The reality is some employers say, well, that's kind of a mean solution, and people get all grumbly about it, and I want to keep my employees happy. Remember, these are, if I'm over here, I'm Goldman Sachs. I'm like, oh, no, these are very high-paid, people. I want to be very nice to them. You can go any pharmacy you want. Well, then I might lose control. So there's this tension that payers have in terms of how much control are you going to give out of the hands of the patient, out of the hands of the physician, to this central authority that you're putting your faith in. If I worked at Yale and they said, okay, you have to drive a Honda, and then I got hired by Harvard and they said, well, now you have to switch to a Ford, was Harvard right or was Yale right? I don't know, and that's part of the challenge we're talking about. The more control you put on this, the more you're taking away things, and I think that creates, there's some trade-offs here.
Yes, right here in the front.
Thank you. Charles Fournier with the Type 1 Diabetes Defense Foundation. I have a question for Elizabeth about patient assistance program and insulin. The list price of analog insulin is about $300, I simplify. The net price paid by payers on Humalog, for example, is about 75% discount, would be about $65. The patient assistance program offers only a 40% discount, which means that the manufacturer derives 3 times the amount of profit out of people who can't afford insulin. Do you think it's fair, and don't you think that the patient assistance program should be offering the net price that they are offering to their payers?
We're now getting beyond my level of expertise and knowledge of patient assistance programs in terms of how they work and what the prices are. But, I just will go back to saying that the ideal is to try to find the patients who are having trouble and try to provide that assistance. So, we put out a transparency report last year. We're getting ready to put out another transparency report that talks about how we run our patient assistance programs, and I would refer you to that. And I'm happy to connect you with somebody who can help answer your questions, but that goes beyond my knowledge of patient assistance programs.
Yeah, I'll just add a little bit, and that is the pharmaceutical companies, many of the pharmaceutical companies actually don't like the couponing either, for the very purpose that Jeff said, and that is it's not accomplishing their goal. That is, their competitor is putting out a coupon also, and it's not successfully moving market share, especially because formularies overlie it, and the formulary can actually dictate which the patient has to do. Recognizing the problem that you're talking about, that there are patients either in the donut hole or patients that actually can't afford their medications or people who don't have insurance, we started a company called Inside RX, in which we are actually giving the rebate to the patient. So you can actually go electronically. It's branded products, unlike the usual coupon programs that are for, or these usual programs that are for generic only. And so this is in cooperation with Lilly, Johnson & Johnson, many other manufacturers, where for patients who want to pay cash, you can actually get the rebated price and pay cash. And so for insulin, for instance, this is one of the biggest uptakes we've had in the program because insulins have been so popular. Actually, the other one that's really big is erectile dysfunction drugs, not surprisingly. But it is a great way for diabetics who don't have insurance to actually get their medications at the lowest price possible.
Have we exhausted our questions? Oh, here's one over here. Yeah.
Hi, this is James Class from Gilead Sciences, and I just wanted to see if we could maybe think of a positive way forward. We did touch on value a little bit, and I was just wondering, is there any potential to address some of the root cause problems here through more creative thinking and value-based insurance design?
Well, that would certainly be something that we would be willing to look at, going back to the point about getting the right drug to the right patient at the right time and being rewarded for it. And if you are able to do that, it's actually affordable for the patient. So would welcome that debate and that discussion. And I think that's, at this point where the industry is and part of the solutions on the table.
So value-based contracting is already in the marketplace. Actually, we even do it with you all. And there's different values you can give. So I'll give you an example. In hepatitis C, one of the things we're doing in a value-based program is we're guaranteeing adherence. If the patient is adherent for all 84 days, we refund to the manufacturer the price, anything they've paid, refund to the payer anything they've paid towards it. That requires us to innovate, right? We had to actually come up with predictive models to predict which patients would take the medication, which one wouldn't. We had to come up with cell phone apps. We had to come up with letter campaigns, call campaigns. But to be very honest, I got the drug so cheap, I was able to even send nurses out to people's homes and shove the pills down their throats if we had to. The reality is because of that, we were able to get adherence rates of over 93%, which is actually greater than what was in the clinical trials. And we were able to save plans and the patients over $1 billion in the first year and successfully treat over 50,000 patients. And so that's an example of a value-based program, but it's different than what you think. On a flip side, what we're doing is we have in place for rheumatoid arthritis or the inflammatory disease categories a discontinuation guarantee. That is, 25%, the docs don't know which drug to start you on when you have rheumatoid arthritis. They don't know if it's Humira, Enbrel, Cimzia, what it is. And so they pick one off the shelf. If you stop that drug for whatever reason in the first 90 days, it doesn't matter if it's non-adherence or if it's not clinically working or if you're having side effects. The manufacturer will refund 2/3 of the money back to you. And at an average of $3,000 a month, that could be up to $6,000 for the first 3 months. So it's an adherence guarantee because essentially for that patient, it's been a defective product. It didn't work for them. And that's a value-based program. So it allows us to have the broadest formulary because we've been able to do it with all the payers. It allows us to give a value above and beyond just lowest net price. And so that's been wildly popular amongst our plans adopting that. And so the trouble for value-based programs, though, is we're going to need the government to help us out. We have to develop safe harbors so you and I can discuss things that may not be in the label, and we have to do something about Medicaid best price if we're ever going to expand it to the federal program. So it only works right now, for the most part, in commercial programs. Seema Verma has shown great interest in expanding this to the government programs. You may have heard her discussion about CAR-Ts. We're doing it on the commercial side. She'd like to do it also on the government side. So I think there's a tremendous runway for value-based programs, but we're going to need some help from the government and the regulatory agencies to give us the safe harbors to do it.
And just to reiterate, that's exactly the direction we should be going, and applaud Express Scripts for everything they're doing in this space. In addition to the government, I think, reconsidering some issues that make it difficult. There's also operational challenges as well, and some of the data challenges. So there's a whole discussion to be had around what tools and policies might make it easier to go down this road, but that's the direction that we'd like to see.
And I think what you see about... What's effective in what Steve said is in action by the PBM. That's something like a call or a reminder or innovation on that side. Let's remember, we're here talking about the patient cost sharing. If you want to say value-based insurance design is, I'm going to have you pay $5 for a generic and $100 for a brand, and the brand has a coupon, the value-based insurance design doesn't do anything. Okay, so that's why the success here, I think, is partially in stuff that's not about cost sharing by the patient. It's value-based, it's the contracts between the manufacturer and the employer and Express Scripts, and it's things like, let's have the nurse visit your house. That makes sense because you're not undoing it with a coupon.
Just a quick follow-up. Quick follow-up. There was colleagues at RAND did a study on waste in the healthcare system. And this is going to be easy. We'll find tons of waste. Well, it's very hard to find a drug, a device, a procedure that doesn't work for some patients. I think the incentives, particularly in pharma world, is when you've invested a lot of money, the marginal costs are close to zero, and it's all profit thereafter. So you push and you try and get the drugs into as many people's mouths as possible, whether they're effective or not. And I think when you talk about sort of risk-based or value-based, is to have risk being shared, have it being outcomes-based. If this drug does lower cholesterol in your patients, then we'll pay. And so the financial incentives for both the manufacturer and the plan are to get the drugs to the appropriate people, not to put them in as many mouths as possible.
And maybe I'll just add one final comment here. As we're thinking about all this, there's also this very kind of delicate trade-off of, we want competition, we want lower prices, which we're getting. The market is getting that. But we also don't want to sort of kill the incentives for innovation. And that is kind of a delicate beast. There's lots of things to invest in. The next version of Candy Crush, an electric car, a space rocket, a new web app. There's so many things you could invest in. But if we want companies and investors to pour money into these very speculative treatments, and if you follow what happens with biotech funding, billions of dollars have been lost chasing things. We have to make sure we don't lose sight of that. We're not going to get a cure for Alzheimer's if someone does actually create one and we say, well, forget it, we're taking it, goodbye, sorry, thanks for your work. We've already invested tens of billions of dollars and gotten nowhere. So I think we need to just, as we're thinking about this, let's not lose sight of this. We've created this very interesting, good innovation engine, and we need to make sure we don't just try to kill it for some short-term benefit, because in 10 or 20 years, our children are going to be very unhappy with us.
So I hope we can all come back to do another panel on optimal incentives for innovation in this sector and others, because I think there's lots of interesting questions there. But I think I'm going to let you guys all go. Thank you so much for being a great audience and asking great questions, and thanks to our panelists.